Peace be upon you and God's mercy and blessings. I am Dr. Hamad El-Sayed, and this is the SIMP Neonatology Channel, where we discuss neonatology topics in an easy and simple way. Now let's get back to academic talk and take on one of the most important topics in neonatology, pediatrics, and medicine as a whole: respiratory support. This is because about 70 to 80% of cases admitted to the NICU are due to respiratory problems, and the same applies in pediatrics. Of course, respiratory support is a big topic, so we'll try to cover it in a connected series, each time talking for about 10 to 15 minutes, because long sessions can be exhausting and boring, and people lose interest. So let's start the neonatal respiratory support series. Welcome. This is an invitation to understand what respiratory support is and what methods we can use to provide it. The first thing you need to know is that respiratory support is not a treatment, so it is not called respiratory treatment. It is called respiratory support. Support means support, because respiratory support is not the primary etiology. The etiology could be in the heart, meaning the patient may have heart disease and there is heart disease present. So you need to support the patient until you treat the heart problem, or for example, the patient may have heart disease, or there is heart disease present, or there is suspicion, or many things can be involved in heart disease. Therefore, you need to support the patient with this condition until the primary etiology is treated, and then the respiration will improve and you can start to reduce the respiratory support. Again, let's start with the topic of respiration. First, I want you to imagine that you are a doctor sitting in the respiratory ward or in the ward in general, and then you get a call telling you that there is a patient with a respiratory problem, let's say pneumonia, and they are bringing him in for admission, so you are supposed to deal with this problem, of course. Keeping in mind that we need many things to diagnose pneumonia, but that's not our topic right now. Let's say you know that this patient has pneumonia and you are going to give him antibiotics, but the antibiotic you will give will need a few days to work. So you need to provide very important respiratory support at first. And before treatment, before you start the antibiotics, you must continue to support the patient from a respiratory standpoint, because the patient may be cyanotic or have severe respiratory distress or apnea or grunting or any other problem. The first thing, when the patient comes to you and you are in the clinic, after they call you and the patient arrives, you will do triaging and classify the patient specifically so you can determine the severity of the condition they are in, and so you can manage them according to that severity. We can easily divide respiratory distress into mild, moderate, and severe. Mild refers to patients who are only tachypneic. Moderate refers to patients who are tachypneic with retraction, and severe refers to patients who are uncompensated, meaning they are in danger. Cyanosis can be accompanied by tachypnea and retraction, but with tachypnea, or this child may be walking around just fine, this is a degree of severe respiratory distress. We also want to say, let's understand three very important words. Not just memorize them, but truly understand them. What is tachypnea? What is respiratory distress? And what is respiratory distress? Repeated for emphasis. We need to understand these three so we can talk about them or recognize them when we hear them. Tachypnea equals fast breathing, but tachypnea means breathing faster than normal, and normal is relative to age. Every age has a normal range of respiratory rate. So anything above that rate, above the normal, is considered tachypnea. There is no such thing as mild, moderate, or severe tachypnea. Even though you might hear some people say mild tachypnea, moderate tachypnea, or severe tachypnea. This is incorrect. Tachypnea is simply tachypnea, fast breathing more than normal. The respiratory rate must be more than normal for the age. For example, in a neonate, the normal is up to 60. If a neonate has more than 60, that's tachypnea. But again, there is no mild, moderate, or severe tachypnea. The second thing is, what does respiratory distress mean? Respiratory distress means difficulty of breathing. Respiratory distress is any abnormal breathing, and this is what has grades. This is what we mentioned. There are mild, moderate, and severe grades. Tachypnea is the first grade of respiratory distress. It is the mild grade of respiratory distress, or grade 1 of respiratory distress. Now, what is respiratory distress syndrome? From its name, it's a syndrome. This disease appears in neonates and is due to surfactant deficiency, specifically in premature neonates, and it's treated with surfactant along with respiratory support. Of course, this has a very significant impact on neonates, and the most important effect and topic among them is RDS. But RDS is a general medical term that can be used for anything. Anyone who has a problem with breathing or has abnormal breathing is a person with RDS. There was even a wise person, I don't know who said that if you notice someone in front of you breathing, then that patient has abnormal breathing. Usually we see and talk to many people and meet them, but it doesn't catch our attention that they're breathing, even though, of course, they're alive. But if you notice that a patient, or not just a patient, any person, if their breathing catches your attention, then they have abnormal breathing. There is a type that we need to know about. You need to know what materials you need in the place where you are, whether in the ER or ICU. You must be able to identify what things you need to do your job. This is one of the most important things you need in clinical practice, not just in pediatrics or neonatology, but in all of medicine. It's not just in pediatrics or neonatology. One of the important things that should always be at the forefront of your mind is knowing the types of respiratory support, how to provide respiratory support. And this is not just in pediatrics. This applies to all of medicine. We know that respiratory support consists of two very basic things, something called invasive and something called non-invasive. The difference between them comes down to three letters: ETT, the end, endotracheal tube. If the patient has an endotracheal tube, that's invasive support. Anything that uses the end, an endotracheal tube will be used, and anything that has an endotracheal tube, anything that uses it will be used. These are the important topics in respiratory support, either used or not used. After that, subscribe to the channel. Anyone who has an endotracheal tube needs a machine, and the machine is called a ventilator. It's just a regular name, nothing to be afraid of, ventilator. You'll find two types of ventilators in every hospital, not just in pediatrics. You'll find something called conventional and something called high frequency. These are the two types of ventilators, and they work in different ways. It's clear even from their names. What is conventional? Conventional means something standard, something that works in the usual way, which is inspiration and expiration. It delivers breaths per minute with inspiration and expiration, and the air contains oxygen, just like natural breathing. We breathe in with inspiration and expiration and take in oxygen with the air, so it works in the conventional way. That's why it's called a conventional mechanical ventilator. As for high frequency, it's an unconventional method, and it relies on giving the patient something. They call it that because you're giving the patient, of course, you're giving him this, but at the same time, if you're giving it, you must be compelled to do so. So the idea of high frequency is completely different from conventional. But logically, when you ask yourself a question and see a high frequency ventilator anywhere, you should know why we use high frequency. For a very simple reason. We failed with the conventional. That is, the patient initially had respiratory distress, severe respiratory distress, and needed a conventional mechanical ventilator, but the patient was still unstable with the conventional. So we moved to high frequency. We talked about high frequency before, a long time ago, and there was a full lecture on high frequency. I hope we can watch it, and God willing, in the coming times, we will do an update about it. An update that is better than previous times, better than the alternating times, which are the times used. You use the times, but they don't have an update about the use times. So you put it on the use times, and you'll put it on the use times, and you'll put it on the times of the use times, so we can understand this topic, memorize it, and know that there's something very important. That gas has types and types and types of character. It has in and out and day. If you put it in a created place, it's very important to understand the word flow. Flow means volume per time. What is volume per time? It means that you have a certain volume, and it could be of gases or of liquids, and then you move this volume. The movement of the volume is called flow. So when it moves, you ask how much moves in how much time. For example, 1 liter every second, 1 liter every minute, 2 liters every hour. The important thing is that there is a volume moving within a certain period of time, and this is called flow. This is a specific characteristic present in air. Therefore, when we provide support to the patient, we take one of the parameters and use a device that gives us one of these parameters in operation. So we can choose something that looks at flow, or we can choose something that looks at pressure, but choosing something that looks at volume is very difficult in the intermediate area because we cannot accurately measure the volume unless it is within a closed system. And in the intermediate area, we cannot do this, but in the intermediate area, that is in the ventilator that is connected via the endotracheal tube to the patient, it is able to more accurately calculate and improve the air volume. But in non-invasive ventilation, we cannot do this because there is a leak and the circuit is not closed, so the device cannot accurately measure the volume. However, we can provide the other two parameters. We can have a device that delivers flow, and we can have a device that delivers pressure. But you need to understand something important here. If we have a device that delivers flow, keep in mind that the flow going to the patient depends on the characteristics of the air, meaning it has a value, but we don't know what it is. The same thing applies if you have a device that delivers air. The air going in is measured because the machine measures it, but as it moves through the circuit, since it's moving, and as long as there is air moving, it has a value, but we don't know it, nor can we know it, because the machine only measures at a certain point. This is just so we understand what the machine is actually doing. So when I tell you that the machine is delivering a certain pressure, you can say, yes, there is pressure, but I don't know exactly how much. After that, we divide the types of non-invasive respiratory support into two very important categories. It can be either 1 level or 2 levels. What does 1 level and 2 levels mean? It's like respiration. In respiration, we breathe at 2 levels. The first level is PEEP, which stands for positive end expiratory pressure. And the second level is PIP, which is peak inspiratory pressure. So you can support patients using either 1 level or 2 levels. But we cannot give PIP alone because PIP is an intermittent pressure while PEEP is a continuous pressure. So the continuous positive pressure can be given with PEEP. Today, you can give it with BiPAP or bilevel or biphasic support. You can give it with BiPAP or biphasic support. You can give it with BiPAP or biphasic support. And you can use a nasal cannula at 1 level of flow because it divides the flow. You can also add flow or high flow. High flow is 1 liter per minute or 2 liters per minute. More than 2 is called high flow nasal cannula. And in neonates, high is 8. And I want to ask a question here for training and practical work. I hope we know it and write it in the comments because we will answer it next time. But we need to train and think, why neonates up to what? After that, in pediatrics, what is the normal flow that you administer in pediatrics? And what does up to here mean? Ask yourself a question. When you set the flow for a neonate, will you give the maximum amount? That was the first question. What does it mean? What does it mean in pediatrics when you give flow to the patient? Will you give them the full maximum? What does this number mean? Let's continue. After that, we say that the nasal cannula delivers 1 level. So it is used in a new way, in a new way, in a new way, in a new way. That is, the nasal cannula works on the same principle as high-frequency oscillation ventilation, as it provides a very high rate because it delivers PEEP as long as it is used in a new way, but it delivers it in a very specific way and at a new level of continuous speed. So how many years has it been around? There isn't much of an idea about this issue, but we will talk about it in the coming sessions after this. This is the flow after that. Pressure. Pressure can be at one level or a second level. There are issues that clarify the pressure in non-invasive machines. So we need to understand them and not get lost or listen to too much talk without knowing where we stand. The first issue is the ventilator. What is a ventilator? We have already talked about it. The conventional ventilator is usually connected to the endotracheal tube, but instead we connect it to a different mask that we place on the nose, so it works non-invasively and gives us either one level or two levels. If it gives us one level, we call it CPAP. CPAP is not a machine. The word CPAP is not a machine. CPAP stands for continuous positive airway pressure. This is a mechanism, a way of delivering air to the patient in a continuous positive airway pressure manner. This is the description of how air is delivered to the patient. So what is the device? The first device is a ventilator that gives us one level, which is CPAP, and it can also give us two levels of pressure. PEEP with PIP. If we give two levels, we call it NIV, meaning non-invasive ventilation. After that, the second machine is called, people refer to it for convenience, or it has become commonly known by this name. But in reality, and this is a very important second question, please think about it. What does it actually mean? BiPAP, of course, is well known, but what does it actually mean? The second machine, which is the so-called BiPAP, gives us either one level or two levels. The single level is called monophasic BiPAP, or some people, for convenience, call it monophasic CPAP. Then, if it gives two levels, it's called biphasic CPAP, or biphasic BiPAP, or for convenience, biphasic CPAP. Now, the third device, which is used in the pediatric ward, is the BiPAP, because it is used in both pediatrics and adults. We can give BiPAP with just one level, which is called CPAP, and we can give it with two levels, which is called BiPAP. But keep in mind that both use the same machine. That is, you can set CPAP on the BiPAP machine, and you can set BiPAP on the BiPAP machine. Again, when using a BiPAP machine, it is used in the pediatric ward, not in neonates. In pediatrics, we can set it to one level of support called CPAP, but the machine that delivers CPAP is called BiPAP. We can also use the BiPAP machine to give two levels of support, which we call BiPAP. There are other machines that are rarely used called bubble CPAP, which is used in some places and by some people, but it is not as effective as the CPAP, BiPAP, or ventilator. But God willing, in the coming sessions, we will also talk a bit about it so that we have an idea. This was a general classification of every type of respiratory support. Before that, we made a general classification of every type of respiratory distress, and we understood what respiratory distress means, what respiratory distress syndrome means, and what tachypnea means, and we learned about all these conditions. After that, we can do matching between these two classifications. For example, when we say that respiratory distress is mild, moderate, or severe, we can match it with the type of support. For example, for children who need flow, we can give them just nasal cannula. For children who need pressure, we can give them pressure support, which could be CPAP, or it could be BiPAP, or a ventilator. The patient who has severe respiratory distress will not be able to manage with just CPAP because it is not enough. He will need a ventilator. It could be moderate or severe, and we can give him CPAP if possible. But when a patient comes in and we need to give him respiratory support, the first thing we need to do is triage the patient and be familiar with the machines and the types of support, as we classified in the big, important classification that you should always know and keep in mind and update for any patient with respiratory distress. You should know what was used and what was not used and what is currently being used, whether it is low flow or high flow, and whether it is by flow or by pressure. We do, or you should do, triaging for the patient who comes to you, and you choose, according to the type of respiratory support, the appropriate type for that respiratory support. That was today's session. I hope it was useful. God willing, in the coming sessions, we will go through each part in detail. Thank you. Peace be upon you and God's mercy and blessings.